of the other issues that we've brought up to the Hill frequently is the whole IPAB group, or the Payment Advisory Board. And NASA as a group has always been against this in the sense that it's 15 non-elected people and no practicing physicians on the group at all. And I guess our real concern is that they're going to be charged with coming up with spending savings when we go over the limit. Yeah. And if the hospitals and the nursing homes are not going to be touched until 2020, what are your thoughts about all that? Is there any chance that they're going to be working next year? Or?
Well, this is part of the President's health law that we opposed adamantly because we saw, as you and NAS have so clearly identified, that you can't put 15 folks who don't necessarily have any experience in healthcare and taking care of patients in charge of determining whether or not physicians ought to be paid for services. This is lunacy. So we're working as diligently as we can, and this is a bipartisan issue. There are a number of folks on the other side of the aisle who believe that the Independent Payment Advisory Board ought to go away. Now the problem with that is that, as you alluded to, their charge is to save money. About $500 billion is their charge to save. And if that money isn't there, then the remainder of the subsidy for the exchanges and the like for the rollout of the President's law doesn't work. I'm hopeful that the Congress and Presidents will be able to unwind the Independent Payment Advisory Board and the other aspects of the bill. But regardless, we need to move forward with a system that doesn't have non-medical people making medical decisions. Decisions in healthcare ought to be between patients and families and doctors.
And doctors, yeah. We touched a little bit on an attempt that was made to get IPAB through. Unfortunately, it was attached to a medical liability legislation as well, and maybe you can tell our members a little bit about why that had a difficult time going through and where we are with medical liability, actually.
Well, John, this won't surprise anybody. This last Congress has been incredibly contentious. The last 2 years, and there's been really little cooperation between the Senate and the House, and there's all sorts of blame to go around, but the fact of the matter is that big challenges are not getting solved, and that's where the Independent Payment Advisory Board fell into a situation where members of the leadership felt that it was important to attach the liability relief H.R. 5 to it. That made it so whenever you attach two or more things together, then it makes it easier to vote no for people. Because they say, well, I may like that, but I don't like that, so I'll vote no. Sadly, that's what happened. But we appreciate, certainly the GOP Doctors Caucus appreciates, that we've got to do away with the Independent Payment Advisory Board, because it will be destructive not just to the practice of medicine, not just to the treating physician out there who's not going to be able to care for the seniors, but it will be destructive to the physician-patient relationship, because the patient won't ever know whether the doctor's recommending what is in their best interest or is going to be paid for.
With medical liability, I come from California, and here we are in Texas, and these are two states that have actually tried to do some tort reform, and amazingly, this seems to be working. My premiums for malpractice are significantly lower, maybe 5 times lower than my colleagues in Philadelphia, for instance. And I think it strictly has to do with how we dealt with medical liability. And California has been going on since the 1970s. Right. Texas was more recent, of course, but both seem to be working. Do your colleagues across the aisle or either other members in Congress look at those two areas as nice testing sites, and what do you think?
Well, the cap on non-economic damages, which is the primary thing that has tended to hold down malpractice rates, has been found to be effective in over 30 states now. It's effective holding down malpractice rates, but I don't think it's effective in doing what needs to be done, and that is changing the practice of defensive medicine, which is where the real money is wasted in our system right now. Jackson Healthcare estimates that the practice of defensive medicine costs 1 out of every 3 healthcare dollars in our country. That's $800 billion. Huge amounts of money. And the cap on non-economic damages, I'm not aware of any study that demonstrates that actually changes the culture of the practice of medicine. So I believe we've got to be more creative. We've got to be more inventive in what we're doing, just as you would do with a difficult patient. This is a difficult patient. You got to figure out how to solve the problem. And I believe that we need to think about and consider making it so that if a physician follows especially society guidelines for a given diagnosis or a given set of symptoms, that becomes an affirmative defense in the court of law. So it becomes a huge hurdle over which the plaintiff and the plaintiff's bar must get in order to even bring the case forward. So that if the doctor does the right thing, they ought not be sued. This is not a firm science that allows for us to dictate or predict every single outcome. Every single patient is different, and so we think that we need to be more creative. This is actually a proposal that has had some interest on the other side of the aisle as well.
You know, it's interesting that you mentioned the comparative effective research. NASS has actually asked that there be some medical liability coverage for doctors who use guidelines that have gone through those comparative effective research studies. And also, we'd like to see if we can protect doctors who go into areas of trauma or disaster because they're doing good things for the area, for the people that are there.
Absolutely. We need more incentives for physicians to stay in the practice of medicine, not incentives for them to get out.